Hello, everybody. My name is Matt Gammons. I'm a sports medicine physician at the Vermont Orthopedic Clinic and Rutland Regional Medical Center. It's my pleasure to be able to reach out to you this way in this brave new world. And we're going to talk a little bit today about return to work challenges and strategies following work-related traumatic brain injury. So one of the things that I think is always very important when someone's given a talk, particularly on areas that may be controversial or where people have differences in sort of how they interpret the literature, is to get a good understanding of where the speaker's coming from in terms of their interpretation. So I wanted to show you this slide. I don't consider myself particularly biased, but I wanted you to understand my interpretation of some of these controversies. I think, and you'll see as we go through the beginning of this presentation, that we really struggle with some of the basic science and basic understanding around concussion. And that really creates some problems in terms of how we interpret this information. I also think you'll hear a lot in the media that lots and lots of people have concussions that don't report them. And I don't think that's necessarily true. I think that there's a mixed bag of things that happen to people, because really what people are underreporting is concussive-like symptoms. And as you'll hear moving forward in this talk, those symptoms aren't always necessarily related to concussion. So there's equal likelihood, probably in most cases, that concussions are overreported as well as they may be underreported. And certainly both can be true given the circumstance in the individual person who's injured. And the last thing that I will say is I don't think just telling somebody that they have a concussion is a benign thing. So if we over-attribute symptoms or things that happen to someone after a head injury to concussion, I think we can cause some harm to the patient, both in their understanding of their injury and both in the option and also in the options that we have in terms of how we treat those injuries. So let's talk a little bit about definitions. And this is one of the areas where we really struggle, because there isn't one standardized definition of brain injury. When people hear mild traumatic brain injury and concussion, these are two terms that are used interchangeably in the scientific literature. They essentially mean the same thing, although some people interpret them to be slightly differently. But this information mostly comes from the trauma literature looking at something called the Glasgow Coma Score. This score is taken when somebody comes into the hospital after being injured and gives us a sense, not necessarily of whether or not they had a concussion, but really the severity of their injury relative to how they may do both in the hospital and when they leave the hospital. But what's really important is this scale alone does not grade concussion for us. And we'll actually talk a little bit further, but we really don't grade concussions in general anymore anyways, because we didn't find it to be a very useful tool. And we were really bad at sort of determining who really did maybe have more mild injuries or more severe injuries. So the language has changed more to, did somebody have a mild traumatic brain injury or concussion, and really talk about the severity of their symptoms rather than the severity of the concussion. The DoD stands for the Department of Defense. Obviously, our armed forces have great concern when it comes to head injuries and blast injuries, and they've done a lot of research on trying to basically help us understand more what these injuries mean. And they came up with this criteria looking at mild, moderate, or severe in terms of the actual traumatic brain injury, not in terms of concussion. And it just gives you some sense of where we look at where things cross over. This obviously is not a stop point scale, meaning there's not a hard point where a mild becomes a moderate or a moderate becomes a severe, but it's really over a spectrum of injury. Two major organizations in this country, the American Medical Society for Sports Medicine, of which I was formerly president, and the American Academy of Neurology, both have definitions that they use, but they're really pretty standard definitions that just say, you have an injury, you have some force that could have been applied to the brain, and we attribute some of those symptoms to be from that. One of the things that's not in this slide is both of these organizations would say that in the absence of other injuries that explain the symptoms. So if you have an injury to your head and we can't explain the symptoms by other causes, then we start to think that might be from a concussion. And you'll see why that's important as we move forward a little bit more in the talk. So I think it's really important to understand where we are too in terms of what happens when somebody has a concussion. And up to this point, and I say up to this point because as you are aware, if you've been watching the news over the past 10 or 15 years, things have changed a lot. But we think that the impact, so the direct impact of the head to something or something to the head, is less important when it comes to concussion than the actual acceleration or deceleration force, meaning that the brain is moving one direction and then the brain stops. So if you imagine that the brain is like a piece of jello or a block of jello, which really is the consistency of the human brain, and it's moving in one direction and it stops, what will happen to that block is it will slide one way and stop, and the side that's on the lagging end will compress a little bit, And then as a result of that, that side will actually rebound. And it's those forces we think stretch the brain cells in such a way to create concussion. Again, there may be other mechanisms that we don't completely understand because it's very difficult to actually measure what goes on inside the brain itself when these injuries occur. So I also think it's important for us to understand the background of where we got this information on concussion. Unfortunately, most of the studies that we have are based on animals. And while these can be useful from the basic science standpoint, they don't necessarily represent the same injuries that happen in people. Any of the studies that we have in people are generally pretty flawed because we don't have that constant definition of concussion. And so you're including people that may have other injuries, that may have had different forces types of injuries. And so it makes it really hard for us to look at those studies and say, this is definitively what's going on with concussion. The other thing that the studies don't do is they don't really try to define well who they included and who they don't include in these studies. So they may just say we included 10 or 15 people with concussion or 20 people or 50 people, but they don't really define how they decided that those people had that injury, which is very important because again, we don't really know how well one doctor, i.e. myself, might compare to another doctor in terms of diagnosing concussion. So I might call something concussion and my colleague might not, and vice versa. But again, this makes it very difficult for us to interpret this data. The other thing that we have to sort of look at is, and again, we'll get into this more again, is that, we'll get into this further again later on in the talk, is that the symptoms that most people describe in concussion are not limited to concussion only. They can be caused by other injuries, not even head injuries, which makes it really difficult. So I don't know, and when we look at the research, and they don't tell me for sure that they've excluded people with other injuries, whether or not we're dealing with groups of people with just concussion or people that have had concussion plus other injuries. And this would make a big difference in terms of how we both approach the research, but how we approach these patients. So again, here's what we think happens in this injury is you have an acceleration, deceleration force applied to the brain. It creates a stretching of the neuron, which we can see there marked by the blue arrow, where part of that cell gets injured, and represented by the sort of triangular shaped picture on the other side, you have this temporary disturbance in how the cell is functioning, and then the cell slowly recovers. And we think that time frame tends to be over about 10 to 14 days. Some injuries might recover a little faster, some injuries might recover a little slower. But that's just the basic cell physiology. That clearly doesn't explain exactly what happens after these injuries and things that go on further, but at least gives us some sense of what's happening at the cellular level. So we know the following. We know, again, it's an injury to an axon, right? Those are the brain cells. And we know those are the cells that are really responsible for cognition and all the things we talk about with memory and thought, and certainly motor control can be part of that with certainly eye motion. There are some other areas of the brain that certainly affect both coordinative things. But these are the cells that really are the master control cells. What's important to remember, what they don't do is cause pain. And again, we'll talk about this in a few minutes, but those cells alone cannot generate a pain signal. So when somebody has pain after one of these injuries, we know that pain is not coming from that cell itself. We also know that the cells that tend to be involved the most, or at least at this point we think are involved the most, are the cells in the middle of the brain. That's an area called the corpus callosum. This is where a lot of the left side and the right side communicate with each other, and certainly may explain why people have trouble with some of the concentration and memory and things that we see after concussion. The areas that aren't commonly involved, interestingly enough, are the areas that involve what we would call our chemotactic center, things that cause nausea, the ocular center, vision. Some of these other centers that may be involved in causing those symptoms in other circumstances don't seem to be the ones that are causing concussion, which can create some confusion for us. All right, here's the greatest problem we're going to talk about in terms of how we move forward from the research standpoint, but I'm going to try to bring this home later on to help us understand what do we do and how do we take care of people with what we know now. But the problem is there's no gold standard. So we don't really have a way to say if we're 100% sure somebody had a concussion or not. It really is based on the type of injury that they had, the presence of symptoms, and then really the experience of the provider. And those three things together will help us determine whether or not we think somebody had a concussion. But I will tell you, having done this for a really long time, it's generally much more gray than it is black and white. When we look at imaging, we take imaging like CAT scans and MRIs because we're looking for bigger structural damage. Neither of those tests show us anything about whether or not the person has had a concussion. We can tell you for sure that the brain was involved if you have one of three cardinal symptoms. That is, you lose consciousness, which is only about 10 to 15% of concussions. If you have true amnesia, and this isn't, I don't remember the millisecond of when I got hit, but you have an extended period of 5 minutes or 10 minutes or sometimes even longer, where you don't recall what happened and you can't remember what happened, or you have true confusion. And I use the example of an athlete who goes to the wrong bench. Now, those latter two, amnesia and confusion, generally are going to come together in the sense that the person who's truly confused usually is going to be amnestic for that later on, but that's not always the case. Almost all the other symptoms that we subscribe to concussion could potentially be because the brain got injured, but also could be because other tissues or other structures got injured as well. So what tools do we use to try to evaluate concussion? So I showed you in the beginning the Glasgow Coma Score. That's really a trauma scale, and the DOD scale. Those are really trauma scales to try to classify severity of brain injury, not severity of concussion. And I know that can be confusing, but in terms of whether or not we're looking at just the concussion itself versus an overall brain injury scenario. We have something called the SCAT-5. We're up to SCAT-5 now, which is the standard concussion, I think it's called sideline assessment tool. You have some tests of the eye motion, you have some balance tests, and then you have something called computerized neuropsychological testing that we'll look at a little closer. But all of these are just tools to use to help us evaluate athletes. They're really not diagnostic. They can be helpful actually probably when they're more negative, meaning someone's able to do well on all these tests, they're probably less likely to have had a concussion. If somebody doesn't do well on these tests, it may or may not mean that they had a concussion. So again, the sideline concussion assessment tool, what's really nice about this is it allows a standardized assessment. So particularly for people that aren't as experienced evaluating concussion, it gives them a way to go through things. Again, it's not a diagnostic tool. If someone doesn't pass components of this, it does not mean they had a concussion, but it certainly means we need to take a timeout. We need to remove them from the game or the circumstance that they're in so that we can evaluate them further. Consequently, if they pass all these tests, again, it doesn't mean they didn't have a concussion, but it certainly means it's less likely. You can see a link in the slide there if you want to look at it. There are, again, several other tests that people have looked at and used. These include looking at the eyes, including tracking in nystagmus, nystagmus meaning that the eyes almost fluttering a little bit as they move from side to side. Obviously, balance testing, looking at memory scores and concentration. There's some other tests looking at reaction time, and the King-Devitt kind of pairs visual cues with cognitive function and tries to see whether or not it's been impaired. Again, all can be very useful in terms of evaluating an acute head injury from the standpoint of do we need to remove somebody from the game or not, or do we need to take them out of a work environment, but they certainly do not tell us for sure whether or not someone has sustained a concussion. And then you have neuropsychological testing that certainly gained a lot of popularity when I was doing my training. It's sort of fallen out of favor a little bit in some circumstances. And the main reason is that this test alone, when I sit at a computer and the computer tests my memory and some other things, is that I may test very different time to time, because not only is it affected by potentially concussion, but could be affected by how much sleep I got, maybe whether or not I had caffeine, what other stressors I have. And so it makes it difficult to know time point from time point whether or not someone really had changes relative to concussion or if they had changes from something else. But again, in certain circumstances, this can be useful to help us evaluate somebody and may be more predictive. Again, if somebody has a negative test, they're less likely to have a concussion, probably less helpful if they have a positive test. The more formal neuropsychological testing, where someone goes for a day or a day and a half, as an expanded version of this, it can certainly give us a lot of information about how somebody's brain is functioning. It can be useful sometimes in helping people restructure work and school. But again, it is not a diagnostic tool to tell us whether or not somebody has sustained a head injury such as concussion. So what else can happen? So I alluded to earlier, there's other things that we need to discuss when it comes to these injuries. For any of you that watch sports or certainly been in an auto accident, you can imagine that neck and other structures can come into play when somebody gets hurt. And we're going to go through some of these structures that can cause similar symptoms, because I think it's important that we understand that it's not that the symptoms themselves don't come from the trauma, but that the symptoms themselves may not come from the concussion. And those are really two separate things. So I think headache is probably the most important one that we talk about. As I stated earlier, the brain itself, so the brain cells are incapable of causing a pain signal. The brain, of course, interprets the pain signal that comes in, and there are structures within the skull that are around the brain that can send pain signals, but those cells themselves don't cause that symptom. So there's some people, and I tend to fall into the camp of this group, saying that, well, we really should separate out post-traumatic headache and concussion, because although they're both head injuries, they're really different head injuries that often may exist together. Now, in saying that, we don't know this for sure. Some of that comes based on the science, some of that comes based on the experience, but we do know for sure that the brain can't cause pain. The two most common type of headaches we see after head injury are tension and migraine type headaches. The migraine headaches certainly make it somewhat confusing because they can cause a lot of other symptoms. But in general, we don't have a good understanding of what causes a tension headache or a migraine headache in the absence of head trauma. We think that some tissues get sensitized both outside the brain and within sort of the what I would call the cranial vault, meaning the structures inside the skull. But it's not always clear why these things would become sensitized and why someone would have a headache. In general, a post-traumatic headache is defined as developing a headache within 7 days of head or neck trauma. That's a bit arbitrary. I'm not aware of any science that says there's a cutoff point for this, but certainly I think the closer to the injury, the more certain you are that the headache has developed as a result of it. There are certainly structures that can cause headaches. So people can have neck injuries that can cause a headache. There's a couple of nerves that come out of the skull towards the back of the neck that have been implicated in the causes of headache. Other soft tissue injuries and something called the trigeminal complex, which is a nerve structure, which has also been implicated in migraines. Those tissues could become damaged and then create these headache symptoms. It's unclear whether or not regular tension headaches or migraine headaches or other type of headaches that people get after head injury, whether or not this is a reflection of true structural damage, or is it more that the head trauma triggered some other process that then caused the headache. But here's probably one of the biggest issues that we have. If we look at the symptoms concussion and we look at the symptoms of migraine, they look exactly the same. And you could even really throw cervical strain into this. People with cervical strain will often complain of similar things, including fogginess. Another name for cervical strain, of course, is whiplash, meaning I've injured my neck. And so it's not clear in many cases when we're treating people whether or not somebody has symptoms that could be coming from a post-traumatic migraine, meaning are they dizzy because of the migraine or are they dizzy because of the concussion? And only sometimes after we've treated some of the potential causes of the symptoms can we figure out what may be causing what. The other things that we see in migraine, and I bring this up because I think it's interesting in terms of some of the research. I think it's maybe slightly less practical in terms of how we treat people. But one of the things that we commonly describe as an eye problem after head injury is convergence insufficiency, but this is also commonly reported in migraine. Nystagmus has also been reported in migraine. When you look at MRI imaging, you also see changes to the white matter in people with chronic migraines, similar to what we attribute to head injury, maybe not exactly the same, but pretty close. When you look at quality of life scores, it's one of the things we get really concerned about in people that have had multiple head injuries. Well, people with migraines actually tend to have much more poor quality of life scores than people with concussion. So sometimes somebody with a post-traumatic migraine may actually have more issues than somebody who simply had a concussion alone. And at this point, it's not clear how we delineate between these two things. We certainly know special testing like functional MRI can show changes after migraine. These changes can be similar to after concussion, and they actually can persist after migraine. So when we look at concussion sometimes and we say, well, we look 2 or 3 months later or 6 months later and we're seeing changes on functional MRI, but we haven't said in that group, are they still having headaches or not? It's hard to know whether those changes are coming from headache or not. And I'll bring up this small point. The other thing about functional MRI, that's just to show you that we don't completely understand. This was a study that was done just looking at, not really a study actually, they were just trying to calibrate the functional MRI machine. So they were using dead salmon. And when they used the fMRI to try to calibrate it, they actually found in dead salmon that the functional MRI was lining up in their brain. So I think we're not entirely clear what all these signals mean. Hopefully in the future, we'll define this a little bit better. Certainly a human brain's better than a dead fish brain, although some people argue that teenagers may be pretty similar. So cervical strain, we talked about this, other commonly called whiplash. If we look at the mechanism of injury, meaning how the forces are applied that we think cause concussion, it's often very similar, whether it be in an auto accident, a trip and a fall hitting the ground, an athlete who gets tackled. These can create very, very similar symptoms to concussion, and yet they're treated differently, which is important. One of the other things that I think is important is we know after you have a neck injury that you actually have a lot of residual problems with sort of the input from the neck. So your neck actually gives a huge amount of input to your brain that help us understand where we are in space. They help your eyes function, they help your balance system. And we're finding that if you don't rehab this after an injury, that people will often not only have prolonged symptoms, but they may be more susceptible to re-aggravating those symptoms. And the best example I can use is that we know when you sprain your ankle, that you may injure the ligaments may heal, but you're still more prone to spraining your ankle. And we think that comes from the fact not that the ligaments didn't heal well, but that the connection between the ankle and the brain has been changed. And if we're not aggressive in trying to readdress that, that you're more likely to have that problem again. And it's postulated that that may be what happens sometimes with some of these neck injuries. And so if we're not doing a good job rehabbing them, we may need to think about that a little bit more. The other thing there's been in the literature that you may have seen is that, is a weak neck a risk factor for concussion? And the answer is we're not sure. We certainly know guys in the NFL have very strong necks and they still get concussions. There probably is something to the fact that if the neck muscles are able to stabilize the head during an impact, that it may mitigate some of the forces that get transmitted to the brain. The problem in many injuries, you're not ready for the hit. So it's one of the reasons they took out in a lot of sports sort of what they call the defenseless player, where you can no longer hit somebody who's not ready for it, because that doesn't give them time to prepare for the impact that then may increase the chances of causing a concussion. So what about the cranial cervical junction? Those are two big long words, but just think about where your head fits onto the top of your spine. There's again, large amount of input from this area that goes into function of the eyes, that goes into function of the balance system. We don't understand certainly enough about it, but we do know that injuries to this area can cause a lot of concussion-like symptoms. We also know that if you take somebody and you just put them in a hard collar and you don't let them move that joint for even 5 days, that you'll have some altered eye movement, you'll have some altered balance. And so similar to concussion, it's hard to know when somebody is being evaluated after a head injury and they may have had a neck injury too, are those symptoms coming from the neck injury? Are they coming from the head injury? Or are they coming from a combination of the two? So just to give you an example of this to try to bring it home before we talk a little bit more specifically about some other issues. This was an Olympic mountain biker. She presented with concern of having recurrent concussions because if she would fall over, she would get dizziness and fogginess. It would usually last 5 to 10 days and return to normal. Well, when we examined this athlete, we found she really had some issues with her upper neck motion and not so much her inner ear vestibular testing. That's what vestibular testing means, that little system in the ear, but in the system that involved coordination of the eyes and the neck. And it turns out that she likely had much more of a problem with her upper neck because as soon as we treated that upper cervical spine and we did some postural retraining, she had a huge amount of improvement, not only in her short-term symptoms, but her tolerance to falls went up much greater, meaning she could fall over on the bike and she was no longer getting those symptoms. So she likely did not have recurrent concussions. She likely continued to re-aggravate this neck injury, which of course is important to know. Not that the neck injury isn't serious, but if you're dealing with an athlete who's potentially worried about long-term health of their brain, we want to make sure that we're giving them the right information. So the vestibular system, again, I alluded to a minute ago, that's the system in your inner ear. It involves a complex interaction between the inner ear, your eyes, and your neck, and certainly the areas of your brain. Post-traumatic vestibular issues are relatively common. Think of this as an input issue rather than an output issue, meaning that the brain's getting bad information from the vestibular system, just like these guys did it themselves by spinning around, and that causes us to be dizzy. One of the take-home points that when we teach providers in terms of taking care of concussion is that true vertigo, meaning that room spinning, that seasickness that people might feel after a head injury, that's rarely a central problem, meaning rarely is that damage to that center of the brain. Almost always that's an issue with the inner ear or some of the other structures around that are giving input to the brain. Different types, I don't want to spend a lot of time on this. I just want you to know vestibular injury is not one thing. The most common thing we see is something called traumatic benign positional vertigo. This is when the little inner ear chambers aren't sending good signal. But there's several other causes that aren't completely understood and may sometimes accompany hearing loss. This is where our colleagues in ear, nose, and throat can help us with some of the testing to help differentiate what types of injury someone may have. Certainly our physical therapy colleagues who specialize or have training in vestibular therapy can also help us evaluate this. And it's important because, again, we treat these issues differently than we treat concussion. And there's a few other ones here post-traumatic Meniere's disease and some other structural injuries that are less common, but that we look for, particularly in someone who's having persistent symptoms longer than we would expect. And I won't go through too many of these. You can look at these, and if someone has questions, my contact's at the end. We also see peripheral nerve injuries. This just means the nerves that when they leave the brain and they go out to do things other places in the body, that the nerve gets injured not at the brain level, but at the outside level. The most common one we see is actually olfactory nerve, which means you lose a sense of smell. But we see other ones. It's not uncommon for me a few times a year to diagnose somebody with an injury to one of the nerves that go to the eyes. And so they've been attributing their eye symptoms to a concussion, and really they had a peripheral nerve injury. Or even if they had a concussion, in addition, they had a peripheral nerve injury. So these things are important to recognize, as oftentimes we're going to do different things for these, and they often have different long-term prognosis in terms of how we might plan for somebody, or if we're doing a disability evaluation, what we might expect. So this is just a list of some of the injuries we see and the types of injuries to the nerves in the chart there. Again, we don't need to go through all of them, but just be aware they can happen. And when we see somebody with some of these symptoms, we need to make sure we have a good exam to either rule in or rule out these as a cause of their complaints. Obviously, mental health, right? This has been a big thing for a long time, certainly in the sports world, but in other worlds in terms of the association between concussion and mental health. The question that we don't know is the association between this. Is it really a causation, or is it just an association? We certainly know that mental health issues have been growing, particularly in our youth, and so it's not clear how many of those might be attributed in athletes to concussion versus other things, because certainly in a non-concussed population, we're not seeing those changes. There was just a recently published study that did not show increased rates of these mental health symptoms in student athletes that had concussion versus ones that didn't. So certainly concussion can probably exacerbate these. Certainly if you're taking out of your sport or taking out of work or you're taking out of your normal life, if we already are on the verge of getting some depressive symptoms, this could certainly exacerbate that. We also know just in general trauma. So somebody has a big traumatic injury that doesn't involve the head. Very, very common to have depressive injuries or even some anxiety after that. So it's not so much that these issues aren't real after head injury, but the question becomes, and it's not entirely clear, is it just the trauma and the consequence of the trauma, or is it actually a structural change within the brain? Again, both can probably be true to some degree in individual people. I think most of the literature at this point would say these are more triggers rather than they are true structural changes, but more information will hopefully come as we study it more. I also talk about what we call cognitive recall bias. I certainly know this is true for all of us, is that in human beings, we have a hard time remembering exactly the way we were. It makes it somewhat difficult on my end when you're going through and evaluating somebody, particularly to evaluate small changes in how somebody feels relative to depression, anxiety, or even how good their memory was or wasn't. We have a propensity as humans to remember ourselves as better than we were. And the old joke about, every year I get further out from high school, the better athlete I was, rings somewhat true. Is that's the way that our brains are naturally wired. So most of the time when people are looking at these things, it's not a malignant thing when they think they were better than they were. It just is a natural thing that we do as human beings. One of the other things I want to bring up, because this comes important with people that have persistent symptoms or people that seem to be okay and then got worse, is you may get something called neuroendocrine dysfunction after a head injury. This is not a result of a concussion, but can be as a result of the same forces that cause concussion. It's actually injury to the pituitary gland, which then results in hormonal deficits. So these can occur anytime after about 3 months to 3 years after head injury. So anytime somebody comes in with symptoms that are after 3 months, or certainly within a few years of an injury and they're worsening, or they may fit this pattern, we want to do an investigation to make sure that we're not missing this condition, because again, it's treated totally differently than we would treat a typical concussion. And this is just the workup a little bit of how we go through and looking at some of the hormonal tests. So one of the questions that I have, and this is again less important, I think, to your world and more important to my world, is we either have to decide that we're going to change our definition or we're going to change our approach. And my personal feeling is we should change our approach. And I think many of us do this naturally. But what we need to do is help define what parts of an injury we think are coming from concussion and what parts we think are coming from other injury, both because I think it's helpful both because I think it's helpful in determining what treatment somebody needs. And it's also helpful in determining what long-term things someone may need in terms of work or schooling or other issues. So how do we approach the evaluation of symptoms? after a concussion, because I think this is much more pertinent, because, you know, feeling not well for a few days after concussion and that gets better is not as much of an issue as somebody is who is having problems prolonged after a concussion. I think one of the things you have to do when we look at an injury is say, does it make sense? Meaning, if an athlete comes to me and says, well, someone just tossed a ping pong ball and it hit me in the head and it gave me a concussion, well, we know that that's not enough force to create one. And vice versa, if I'm on the field somewhere and I see somebody take a really big hit and they seem okay, well, I might want to check that person closer because they clearly had a force that may have been enough to cause a concussion. Now, in practicality, many times we can't tell the difference, but I do think it's important to separate out, does the mechanism make sense? When we evaluate, one of the first things I do is I'm evaluating for other associated injuries. Certainly in the acute setting, we're looking for bleeding and other structural things that need emergency evaluation, but really more commonly in the office setting, when we're seeing them down the road, we're looking for other things that may affect their recovery. Do they have signs of neck injury? Do they have signs of inner ear injury? Because we're going to break those out and treat those differently than we're going to treat just a concussion. One of the other things you want to remember in the evaluation, and this is one of the things I tell people, is that, you know, when we get hurt, whether it be a head injury or other injuries, you know, unfortunately, life doesn't stop. And so for a lot of people, these interruptions in their normal life really start to pile on. And when they pile on, it can make the highs not seem so high, make the lows not seem so low. But it really probably is more a function of a traumatic disruption. And I think I talked about this briefly earlier, rather than always necessarily this is from a chemical change in the brain that was caused by concussion. So treatment. Well, it's very simple to say, and it's probably obvious that we take the individual and we base our treatment plan on what we're finding. But I always tell patients that the treatments that we have for concussion are really threefold. There's two listed here, but three. It's relative rest, which means complete rest isn't good. Doing everything normally probably isn't good. Somewhere in the middle based on how they feel. Exercise, meaning getting your heart rate up for up to 30 minutes a day, even if it's in short bouts initially, have been shown to help the recovery. And what I would call just healthy lifestyle, making sure you're getting enough sleep, making sure that we're reducing stress. All those things can affect brain function, because the brain is a very, very complex thing we have very, very little insight into. But I think all of us have experienced being stressed or being tired or a combination of both. And when we are that way, our brain doesn't function normally. So we want to take out that extra load when somebody's trying to recover from a concussion. And then we want to go look at what other things could be causing their symptoms, whether it be neck pain, whether it be headache, whether it be vestibular injuries. And we want to treat those in parallel with the concussion. Because as we treat those injuries, it sometimes becomes apparent what symptoms may be coming more from concussion, what symptoms may be coming more from a neck injury per se. And for example, so if somebody comes in and they have a whiplash injury and we think maybe they had a concussion, but we're not sure, and they complain of fogginess, and they go to therapy, and after a few visits, the fogginess clears as their neck pain's getting better, well, then that was probably a neck-related phenomenon, not a concussion-related phenomenon. Or if their neck pain is getting better and their neck motion's getting better, but they still feel foggy, well, then that fogginess is maybe coming from a concussion rather than the neck. And again, it's not always crystal clear, but we can get an idea sometimes as we move forward with treatment. Returning to work is similar to returning to school and returning to sports. You know, again, the relative rest part is, you know, some people can go back the next day. Some people need longer. Working is tolerated is very reasonable even early on, but it depends on how safe the environment is. So certainly a ski patroller or somebody working, you know, up on telephone poles is going to have a different work environment than somebody who's sitting at a desk. And so we need to adjust and accommodate them as best we can to make sure that they have a safe work environment. But in actual using their brain in terms of cognition is good in that relative rest setting, meaning that sometimes they're not going to be able to tolerate full hours, but even doing what they can is better than doing nothing at all. And we obviously want to gradually increase activity as symptoms allow. It is not a perfect science. Just like rehabbing somebody from another injury, sometimes you might push too hard and you might set them back a little bit. There's other times when you may have been able to push a little harder and you didn't. And so we have to use judgment and the individual person and the individual circumstance to help them get back to work. But I will say in general, obviously returning someone to their work environment as quickly as we reasonably can tends to help people do better overall than keeping them out longer. Post-concussive syndrome, just remember with this, there's no universal definition. It really is defined best as, do you have symptoms longer than we expect after a concussion? And that's generally 2 to 3 weeks in adults and 4 to 6 weeks in children. I, over the years, have become much more aggressive in looking for other causes of those symptoms early on, even at the first evaluation, because I think there's some benefit, and there's some ongoing studies that are showing us some benefit from addressing those other issues sooner. But, in the end, there are a lot of people that would say, well, look, you should just let these settle out for a few weeks because a lot of the symptoms will get better regardless of where they're coming from. And this is true in many cases. One of the things that we see that's common in adults in terms of return to work is with this concept of cognitive fatigue. We don't have a great understanding of it. It's best explained by the fact that my brain works normally, but it can't work as long. So, for example, if we put it in running terms, somebody who could run 5 miles before the injury can still run 1 mile, but that's all the endurance they have. In the work setting, it may be that they are feeling pretty good and work normally for 2 or 3 hours, but then the rest of the day, their brain's not functioning pretty well. This universally tends to recover with time. And exercise seems to be helpful with this, and certainly stress management. It's one of those scenarios where often someone can go to work and work part-time, but they just have trouble making it through a full day. Again, other prolonged symptoms, it's not as clear. We're not entirely sure why some people may have symptoms that last up to 12 to 18 months. And there are even some studies that show that people have symptoms lasting much longer than that. I think my interpretation of most of it is that it's very individual. Some people may have some post-traumatic headaches that don't go away, and we're attributing that to post-concussive syndrome. There may be some injury that we can't even evaluate based on our current testing. So we don't know, and maybe we'll know in the future that we said, oh, we couldn't identify this injury in the past. Now we can identify this injury. Similar to what I would say like a stress fracture. We used to not be able to identify stress fractures very well on x-ray. As soon as MRI came along, we were finding lots of stress fractures we never knew were there. So there may be some advances moving forward where we'll find some other injuries that have occurred that we don't understand. But at this point, it does seem that most people will return to relatively normal cognitive function with 12 weeks, but that there's certainly a subset that's affected longer, and it's not clear why. So what do we do with symptoms last? Well, it's back to what we talked about. We want to look for associated injuries, and we want to assure healthy lifestyle, things like stress management. There is some evidence that counseling, cognitive behavioral therapy can be helpful for individuals that are having symptoms longer than we would expect. I think one of the keys for me is I always express to people that we believe that they're having symptoms. We just don't always know why they were there. And sometimes they're hard to link to the head injury, particularly when you get really far out from an injury. So long-term, like I said, it's unclear what these causes are. We think, based on the best information we have in the medical literature, that true malingering is pretty rare. And I don't think most of the patients that come in to see me are really not trying to get better. I do think sometimes they're concerned. I do think sometimes they're worried. I do think sometimes we suffer that what I call cognitive bias in terms of that recall bias. I think there's things that are ongoing in the background that can be helped by education and counseling. I also think that trauma itself can trigger underlying conditions. And I think we certainly see people that may have had some mild depressive symptoms that they either weren't dealing with or that really weren't identified. They have a head injury or a trauma. It takes them out of their normal routine, and it really tips them over into this depressive time. So even though it was perhaps a cause, it was more of an indirect cause of their ongoing symptoms. So long-term, we do think most of these injuries recover without long-term consequences. If you look at large epidemiological studies, to the best of our knowledge, there's not a significant increase in mental health issues or what we would call neurocognitive disease, things like Alzheimer's. But there is some mixed evidence, and this stuff can be really, really hard to tease out. And certainly there are some groups that are probably going to have some prolonged issues after head injury. Whether or not these are triggered things that come from the head injury, whether or not they're direct structural things, isn't always easy to tell. So one of the commonly things that we talk about with long-term injury that was in the news a lot, something called chronic traumatic encephalopathy. I think a couple things are important to be reminded of this. Number one, it really is a hypothesized neurodegenerative disease. And what I mean by that is we're finding this protein deposit in people that have had repetitive head trauma, but we don't really know what it means. And I think it's become clear in recent years as we're finding this type of protein in non-contact athletes relatively frequently, such as baseball players and other players who don't frequently hit their head. And the fact that we see really three groups of athletes. We see people that have this protein called tau that have symptoms of neurodegenerative diseases. We see people that have no tau and have neurodegenerative disease symptoms. And then we see people that have tau and they have no symptoms. And so there doesn't appear to be a direct relationship between what we're seeing on scans or even after depth in looking at the looking at the pathology of the brain and what people were experiencing. That doesn't mean there's not some link in this. We just haven't really figured it out. It could be related to some other things, such as the amount of time that they spent doing particular activities, taking particular supplements. I mean, there's lots and lots of things that people are looking at, but it's not entirely clear why some people might develop this condition and whether or not it really is a condition of head trauma or it's related to something else. So what's the take home, I think, for you today? And I realize this has been a slightly different type of talk, so I appreciate you being patient. But really, symptoms after head injury don't always equal concussion. And that doesn't mean that somebody can't have both. Sometimes you have both a concussion and a neck injury. But I think it's really important that we understand there's other things that come as a consequence of these traumas that is not just the brain. We want to evaluate that well so we make sure that we're getting people the treatment that we need. At this point, it's not entirely clear that if we treat some of these other injuries early, that people are going to get better. I will tell you that in my experience, if we identify neck injuries and some of these other injuries earlier on, that I think people do get a leg up in getting back to work and in their treatment if we identify them early on. I also do think it saves people sometimes some what I would call mental health issues, meaning if somebody comes in and they've been diagnosed with a concussion and they're really concerned about it, but I can reassure them based on the best information we have that I really think they had a whiplash injury instead. I think that's valuable, and that can be valuable to people in moving forward and getting better. We know that, again, relative rest and exercise are really the only treatments we have for the brain injury itself. Perhaps in the future, we'll have some better treatment options for people with these injuries, but I always explain to people that the reason I spend so much time looking for other injuries is not because I don't believe they had a concussion or didn't have a concussion, but I really want to make sure that I'm treating all the injuries they have, not just attributing everything to concussion. I think, referral to concussion specialists is kind of a tricky thing. Access to them can be difficult. Sometimes access to me can be difficult. And I think there's not across the board a concussion specialist that is sort of the person or the group of people, whether it be neurologists or physiatrists or sports medicine physicians like myself, that are really the experts. I think the expertise comes from both treatment and experience. It's understanding the limitations of what we know and what we don't know. I know some very, very good primary care doctors who are excellent at this and have a great understanding of what's going on. I know some neurologists that don't deal with it at all and really aren't up to date on it. So if you're looking for someone, you really want somebody who understands, I think, the big picture with these injuries that we discussed today, not just because somebody has this particular specialty or they don't have the specialty. I would say symptoms lasting longer than 2 weeks only because a large percentage of people are going to get better within a couple of weeks and they don't always need that additional evaluation. So I realize in this format that you guys are going to have the opportunity to ask questions. I'm happy to take questions by email. I am not always the best at responding in a incredibly timely fashion. So if you don't hear from me, feel free to poke me a second time. You can also find me at the Vermont Orthopedic Clinic, which is online or certainly through Rutland Regional Medical Center. And I really appreciate you taking the time today to listen to this lecture. Thank you.